Okay. Today, my talk would be on an approach to the patient with drug allergy. So I think this is a timely topic. And yeah, in this presentation, I will talk about steps in evaluation a patient with a drug allergy and what is the definition of drug allergy and how to classify adverse drug reactions and pathogenesis of drug allergy and risk factors for drug allergies and for how systematically approach a patient with an allergic reaction and a little bit about penicillin allergy. So when a patient develops a reaction following a administration of a drug, so there are a few questions arise in our mind. So first would be, is this adverse event actually related to a drug or could it be something else? So if it is so, then if the reaction is due to an immune response to the drug or is it due to another mechanism? So then if the reaction is a drug allergy, then what would be the likely mechanism? Then more importantly, how severe is the reaction? Then which drug is responsible? And finally, how can the necessary therapy for this underlying medical condition can be continued in spite of this allergic reaction? So what is a drug allergy? Type of adverse drug reaction that is caused by an immunological reaction elicited by a drug. So it usually accounts for 5 to 10% of all adverse drug reactions. And these drug allergies may actually lead to delayed treatment and use of suboptimal alternative medications and unnecessary investigations as well. Therefore, correct identification of drug allergy is very important. So as it is type of adverse reaction, then I will talk about these adverse drug reactions. So what is an adverse drug reaction? So it is a general term referring to any untoward reaction to a medication. So these adverse drug reactions can be classified into type A reactions and type B reactions. Type A reactions are usually predictable from the non-pharmacological properties of a drug. These comprise of around 85 to 90% of all drug reactions, and these can actually affect any individual. So examples for these type A reactions are gastritis due to NSAIDs and commonly diarrhea due to antibiotics. Type B reactions are usually unpredictable and they occur mainly in susceptible individuals. They represent mainly hypersensitive reactions and idiosyncratic drug reactions. So I will come to hypersensitive reactions later. So these idiosyncratic drug reactions are usually occurring due to genetic differences in patients. For example, primaquine causing non-immune hemolytic anemia in patients with G6PD deficiency. Another example would be azathioprine toxicity in patients with thiopurine methyltransferase deficiency. So what are these hypersensitive reactions? These hypersensitive reactions can be further divided based on timing of their symptom onset and based on their mode of action and based on immunological mechanism. So based on timing of onset, these can be divided into immediate reactions and delayed reactions. Immediate reactions usually occur within 6 hours of exposure to a given drug, and common clinical features would be like urticaria, angioedema, bronchospasm, and more importantly, anaphylaxis. Often these are IgE mediated, but IgE independent reactions can also occur. Delayed reactions usually occur after 6 hours of exposure to a given drug, but most of them will occur early in the second week following drugs. Most of them are benign, but severe reactions such as DRESS, Stevens-Johnson's, and acute generalized exanthematous pustulosis, commonly known as SCARS, severe adverse cutaneous reactions, can occur as well. Mostly pathophysiologically, these are T-cell mediated. Based on mode of action, again, hypersensitive reactions can be divided into drug allergies or immune reactions and pseudo-allergies. Drug allergies, as I described earlier, is a type of adverse drug reaction that caused by immunological reaction elicited by a drug. So then, what are these pseudo-allergies? So these will resemble immunological drug reactions, but they lack evidence of specific immune system involvement. In these, drugs will bind directly to the effector cells of the immune system in such cells such as mast cells, and they will cause reactions similar to IgE-mediated reactions. So they may develop urticaria, angioedema, or anaphylaxis as well. Common examples for these pseudoallergies are exacerbation of asthma following NSAIDs or aspirin, flushing during an infusion of vancomycin, hepatitis due to isoniazid, and anaphylaxis due to radiocontrast media. So then, hypersensitive reactions can further be divided based on the immunological mechanism. So it is called Gell and Coombs classification, and this is the most commonly known classification. So in this, we divide hypersensitive reactions to four classes, mainly type 1, type 2, type 3, and type 4. Type 1 reactions are usually immediate in onset and they are mediated by IgE and mast cells. Clinical features are anaphylaxis, angioedema, bronchospasms, or urticaria. Type 2 reactions are antibody-dependent mechanisms. Clinical features are hemolytic anemias, thrombocytopenia, and neutropenia. Type 3 reactions are immune complex mediated. Clinical features would be serum sickness and arthritis reaction. Type 4 reactions are cell-mediated or they are, can occur due to delayed hypersensitivity reactions. Commonly, they may present with contact dermatitis, rest, and interstitial nephritis as well. So, then a little bit about pathogenesis of drug allergies. So, drug allergies commonly occur in two ways. In one way, that drugs may act as an antigen and they will elicit one of these classical immune responses. Usually, drugs are small molecules, so they are incapable of eliciting immune reaction by interacting with immune receptors. But certain drugs, such as penicillins and other beta-lactams, may bind to host proteins and they may become larger molecules and these may become immunogenic. So when the drug is bind to host proteins, these are called hapten, and this complex with drug and host protein is called a hapten carrier complex. And these complexes are capable of eliciting an immune response by interacting with immune receptors. So other ways, drugs may interact directly with immune receptors and they may lead to activation of specific immune cells. This is actually an off-target activity of the drugs because they will interact with certain T-cell receptors or HLA molecules that are not their primary therapeutic targets. Examples for these reactions are phenytoin and carbamazepine. So then, what are the risk factors for drug allergies? So there are a few risk factors that are female sex, prior history of allergic reactions, recurrent drug exposures, certain HLA types, and certain disease states. So why female sex is more prone for allergy is actually unknown, but they are more prone for allergic reaction for some drugs, for example, gemifloxacin, a macrolide, and they may have more delayed reactions. But for commonest allergies with penicillin, there is actually no gender differences. Certain HLA types may cause increased risk for allergic reactions with carbamazepine, mainly with carbamazepine. Certain disease states such as HIV and leukemias may also increase the risk for drug allergies. So then importantly, so how we systematically approach to the patient with the possible allergic reaction. So as I said earlier, as the first step, so what we have to think is the adverse event actually related to this drug or could it be due to something else? Because most of these immediate reactions such as hypertension, shortness of breath may be due to disease itself or may be due to sepsis or it may be due to any other allergy, maybe a food allergy occurring at the same time. So we have to keep in mind when a reaction occurs following a administration of a drug that it could be not related to a drug, it may be due to some other cause as well. So if it is due to a drug, then whether it is an allergy, that means immune reaction, or is it a pseudo-allergy. So for that, careful evaluation of history and proper examination will be very important. And in that type of situation that we have to keep in mind, so what are the most common drugs that can cause pseudo-allergies? So as I said earlier, NSAIDs causing exacerbation of asthma and flushing during vancomycin infusion. So next step would be, if the reaction is a drug allergy, then what mechanism it is, whether it is a type 1, type 2, type 3, or type 4 reaction. That is mainly via depending on the clinical symptoms and the susceptible drugs. Then importantly, then how severe is the reaction? This is basically done via thorough examination, including respiratory system, cardiovascular system, and we can do some additional investigations, including full blood count, renal function test, and liver function test as well. So then, which drug is responsible? Because some patients may be given few drugs at the same time, so we don't know which drug might have caused this allergic reaction. So clinical history and reviewing medical records is important. And also, we have to look for drugs with high allergenic potentials, such as beta-lactams, NSAIDs, anti-epileptics like phenytoin, carbamazepine and lamotrigine, and allopurinol. Then a bit about this objective testing. So what are the testing available for these immediate reactions and delayed reactions? For testing for immediate reactions, we basically do markers of anaphylaxis. We can do tryptase levels and histamine levels, though these are rarely available in government sector or private sector in our country. With tryptase level, these are ideally done within 1 to 3 hours from onset. Tryptase levels more than 9 nanogram per milliliter during anaphylaxis or more than 3 nanogram per milliliter on following day is suggestive of anaphylaxis. The issue with tryptase level is that normal levels will not exclude the diagnosis of anaphylaxis. There are also some skin testing for drug-specific IgEs available, but these are mainly used for evaluate suspected type 1 reactions. There are drug-specific Ig testing available for penicillins, other beta-lactams, and some chemotherapy drugs such as statins. There are in vitro testing available, such as solid-phase immunoassays and flow cytometries, but these are mostly in research settings, not used in day-to-day clinical practice. Then, how we test for delayed reactions? That evidence for testing for delayed reactions are low, but there are delayed intradermal testing and patch testing available. Both of them are usually we do after 6 weeks to 6 months after complete healing of a reaction. So for delayed intradermal testing, we take it as positive if there is any induration at 24 hours. For patch testing, it is done mainly for type 4, and we take it as positive if there is any infiltrated erythema at 24 to 72 hours as per International Contact Dermatitis Guidelines. There are also in vitro testing available for delayed reactions as well, such as cytokine production, lymphocyte transformation or activation test. These are again mostly in research settings and not validated for clinical practice yet. Then another way that we can test for allergic reaction is we can do a drug challenge. This is also called graded challenge, but drug challenge would be the better term. So it involves administration of a medication to a patient in a graduated manner under close observation. These are mostly appropriate for patients who are unlikely to be allergic to that drug. So how we get a clue about that is that if the how remote the index reaction was, or if the clinical features are just benign cutaneous signs, or if there are higher number of listed drug allergies are documented, or if those documented drugs are rarely or infrequently causing allergies. So there are few contraindications for these drug challenges, that if the patient's reaction was such as Listerine dermatitis, DRESS, erythema multiforme, severe anaphylaxis, Sweet syndrome, or vasculitis, we have to avoid these drug challenges. So there are different protocols available for immediate reaction testing, immediate reactions and delayed reactions. In immediate reactions, there are one-step methods and two-step methods are available. In one-step method, we can give either one full dose of oral drug, or full dose of intravenous, intramuscular, and subcutaneous dose, and then we can observe the patient for 30 to 60 minutes. In two-step method, as the first step, we can give quarter tab orally of or one-tenth of the intravenous, intramuscular, subcutaneous dose, and we can observe for 30 to 60 minutes. So after 30 to 60 minutes, as the second step, we can give full dose and again observe for 30 to 60 minutes. So we take this as a positive reaction if the patient is developing urticaria, angioedema, hypertension, and anaphylaxis, and those symptoms. Doubtful reactions are like dizziness, tachycardia, and transient pruritus without a rash, and headache. There are also protocols available to non-severe delayed reactions. Again, we can do it as a one-step and two-step method. Again, same like in the immediate reactions. So criteria of positive reaction is if the patient is developing fever, urticaria, facial swelling, and target or atypical target lesions. Again, the reaction is a doubtful one if the patient is developing symptoms such as dizziness, tachycardia, transient pruritus without a rash. So most important step. So how can the necessary therapy for this underlying medical problem can be continued in spite of this allergic reaction? So it can be done via mainly three ways. One is we can administer unrelated medication. For an example, if the patient is having a penicillin allergy, we may give a macrolide. Or we can administer a related medication under close medical observation. Example would be giving a cephalosporin to a patient with penicillin allergy. Or otherwise, we can desensitize the patient to the culprit drug. So what is this desensitization? So it is a procedure that will alter the immunological consequences of drug hypersensitivity, and it will result in temporary tolerance to that drug. So it will allow the patient with this hypersensitivity reaction to receive an uninterrupted course of medication safely in the acute setting. But issue with this desensitization is that once the medication is discontinued, the patient's hypersensitivity will return. So in most situations, this should only be performed by allergy specialists trained in the technique. And there are specific protocols available for different drugs, such as NSAIDs. So then, how the long-term management of patients prone to drug allergies can be done. One thing we can do is we can limit the antibiotic use unless for a clearly indicated cause. If we need to start on any antibiotic, then we can start it at a lower dose whenever feasible, and we can administer it under close medical observation. So then, a little bit about penicillin allergy, because it is the most commonly reported medication allergy, and up to around 15% of the patients who are coming to the hospital will report some type of penicillin allergy at some time of their life. But at the end, many of these are found not to be allergic to penicillin. So penicillin-induced anaphylaxis will occur with an incidence of 1 to 4 episodes per 10,000 administrations. There are some cross-reactivity occurring with penicillins, but it is also a very low percentage. For example, with cephalosporin, cross-reactivity is only 2%, and with carbapenems, it is less than 1%, and for monobactams, actually it is not relevant. So how to approach to a patient with past history of penicillin allergy who require antibiotics. So careful history taking and reviewing past records will be very important, because if we go through his past records, that allergic reaction could actually be just a nausea, vomiting, or just a side effect of the drug. So if we can come to that kind of a conclusion with the history and by reviewing past records, we can treat the patient with penicillin or any other related medication. But if the patient had a serious type of reaction, such as Stevens-Johnson's, then we have to treat the patient with aztreonam or non-beta-lactam antibiotic. So if the past reaction is a Ig-mediated reaction, then we can treat the patient with either third-generation cephalosporin, carbapenems, or any unrelated non-beta-lactam antibiotics. Or we can give penicillin or first or second-generation cephalosporin with a test dose procedure or a drug challenge. Or if the fast reaction is without Ig-mediated features, again we can treat the patient with either third-generation cephalosporin, carbapenems with test dose procedure, or aztreonam or non-beta-lactam antibiotics. So then, why delabeling of these patients with penicillin allergy is important? Because more than 90% of individuals with history of penicillin allergy will tolerate a penicillin again. So we might think this penicillin allergy is benign, but it may not be benign because it may lead to less effective and more toxic and more expensive drug administration. And also, studies have shown that these patients are more likely to develop MRSA and vancomycin-resistant enterococcus as well. So delabeling is important, so it can be done via skin testing and penicillin challenges to confirm. So in a summary, drug allergy is an adverse reaction due to an immunological reaction. Adverse drug reactions can be classified depending on timing of symptom onset, mode of action, and immunological mechanism. There are multiple risk factors for drug allergies, and diagnosis of a drug allergy needs systematic approach. Different types of testing are available for different types of reaction. And penicillin allergy is not always benign. Thus, delabeling in a proper way is very important to clinical practice. So my references are mainly from UpToDate and 2022 Drug Allergy Practice Parameter Update by American Academy of Allergy, Asthma and Immunology. Thank you very much.
Thank you. It's open questions. Thank you, Dr. Jivan, for the presentation. So